Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 462 of our pharmacotherapy series, which majors in pediatric malignancies. The next case reads, DSB, a 16-year-old girl, presents with a history of shortness of breath and chest pain for 3 weeks before admission. A mediastinal mass is found, and a biopsy confirms a lymphoblastic, that is T-cell, lymphoma. Radiography of the chest reveals a right pleural effusion. Laboratory values show the following results: an erythrocyte sedimentation rate of 35. A WBC count of 22,000 cells per microliter. Uric acid levels of 7 mg per deciliter. Lactate dehydrogenase of 1,259 units per liter. The bone marrow, CNS, and abdomen are negative for lymphoma. So my questions to you read: how should DSB be managed acutely? Besides chemotherapy, what types of adjunctive therapies should be initiated to minimize the acute effects of treatment? Given DSB's shortness of breath and chest pain, it is likely that her mediastinal mass may be obstructing the superior vena cava. To alleviate this obstruction, the most appropriate course of action is to decrease the tumor mass by initiating chemotherapy as soon as possible. Radiation therapy offers no additional benefit in patients such as DSB with a tumor such as non-Hodgkin lymphoma, which is highly responsive to chemotherapy. Because of the high cell kill that will result from the initial chemotherapy treatment, tumor lysis syndrome and uric acid nephropathy are possible. However, the risk of this complication is probably greater in patients with B-cell non-Hodgkin lymphoma in whom the fraction of cells in S phase is higher. Alkaline diuresis and allopurinol should be instituted before chemotherapy to prevent tumor lysis syndrome. Because DSB has a pleural effusion, fluids may collect in this third space, resulting in weight gain and decreased urine output. Thus, in addition to placement of a chest tube with suction, DSB should be given diuretics to maintain an adequate urine output. To minimize intravascular volume depletion and maintain electrolyte balances, fluid input and output, body weight, and electrolyte panels should be monitored daily. These values should be used to make appropriate adjustments in DSB's electrolyte and fluid balance. DSB is treated with the Berlin-Frankfurt-Munster, abbreviated as BFM combination chemotherapy regimen. Because of her intrathoracic mass, her disease is characterized as stage 3. She is to receive induction therapy, induction protocol 1, for 8 weeks. So my questions to you read: Which acute adverse effects is DSB likely to experience with these agents? How can they be monitored, minimized, and treated? Several toxicities are expected with these chemotherapy agents. For vincristine, both constipation and neuropathy are likely to appear during or after the 4 weeks of therapy. Constipation can be prevented or minimized by use of stool softeners with or without a laxative. Neuropathy may be painful, especially when jaw pain occurs, but can be managed with mild analgesic regimens consisting of non-steroidal anti-inflammatory drugs or acetaminophen with codeine. Both toxicities are self-limiting and are not reasons to discontinue or decrease the dosage of vincristine unless neuromuscular toxicity, as evidenced by motor weakness, develops. The incidence of jaw pain and foot drop is higher in pediatric populations as compared to adults. Asparaginase can cause several types of toxicities, e.g., hypersensitivity reaction, coagulation disorders, or pancreatitis, most of which are not thought to be preventable. Prednisone is likely to increase DSB's appetite and may cause gastritis, although divided doses will help decrease stomach upset. In addition, prednisone-induced behavioral disturbances, such as hyperactivity, are common in children. Unlike prednisone and vincristine, daunorubicin, cyclophosphamide, cytarabine, and mercaptopurine produce significant myelosuppression. Leukopenia is common, with the nadir occurring in approximately 8 to 14 days, and recovery occurring by approximately day 21 after administration. Because the goal of induction therapy is achievement of remission, doses of daunorubicin will not be held for uncomplicated myelosuppression during the first 4 weeks of induction therapy, although during the latter 4 weeks, the combination of cyclophosphamide, cytarabine, and mercaptopurine are typically held until hematologic recovery occurs. Hemorrhagic cystitis may occur with cyclophosphamide, but it is usually associated with high-dose therapy or with prolonged administration, which DSB is not receiving. Vigorous IV hydration to maintain urine output of approximately 50 to 100 ml per meter squared per hour should reduce the risk of this toxicity at this dose. In addition, this chemotherapy protocol also includes mesna, which will bind to urotoxic metabolites of cyclophosphamide and also reduce the risk of hemorrhagic cystitis. Because most of the induction regimen will be administered on an outpatient basis, patients or parents should be instructed to report signs or symptoms of infection, e.g., febrile episodes, immediately so that proper treatment may be instituted as soon as possible. To decrease the risk of hemorrhagic cystitis, parents should be instructed to report whether patients are urinating regularly after cyclophosphamide. Nausea and vomiting are likely to be induced by both daunorubicin and cyclophosphamide cytarabine. DSB's chemotherapy regimen includes a corticosteroid, such as prednisone, which may provide some antiemetic activity during the initial 4 weeks. However, to maximize tolerance to her chemotherapy, DSB should receive a 5-HT3 serotonin antagonist. DSB is unlikely to require additional corticosteroids during the first 4 weeks of induction therapy. However, during the second portion of induction, DSB will benefit from a few doses of dexamethasone at the time of cyclophosphamide administration. My next question to you reads: what is the importance of CNS prophylaxis for DSB and what type of treatment regimen is typically used? All pediatric patients with lymphoblastic lymphoma should receive some form of CNS prophylaxis. Although lymphoblastic lymphoma rarely presents with CNS involvement, as illustrated by DSB, it was a common site of relapse before CNS prophylaxis was included as a routine part of the chemotherapy regimen. Recurrence of non-Hodgkin lymphoma within the CNS is rare when intrathecal methotrexate or cytarabine is given. DSB will be treated with intrathecal methotrexate periodically. After completion of induction therapy, the chemotherapy plan for DSB consists of Protocol M and Reinduction Protocol 2. My next questions to you are: how should DSB's hematopoietic recovery be managed, and what guidelines may be used to determine when it is appropriate for her to receive the next sequence of the treatment cycle? Would DSB benefit from a colony-stimulating factor to aid with hematopoietic recovery? Protocol M will likely not produce significant myelosuppression because leucovorin rescue will reduce the myelosuppression from the high-dose methotrexate. The most challenging problems with this phase of treatment will be to confirm that the methotrexate has been properly eliminated and to continue aggressive hydration, alkalinization, and leucovorin dosing until the methotrexate level is non-toxic. Owing to DSB's pleural effusion at the time of diagnosis, it should be confirmed that this has resolved before administration of high-dose methotrexate to avoid significantly delayed clearance, because the pleural effusion could allow for third spacing of high doses of methotrexate. Pleural effusions are a relative contraindication to high-dose methotrexate. Methotrexate elimination has high interpatient and intrapatient variability, and necessitates close monitoring of methotrexate concentrations and renal function after each dose. Refer to the discussion of high-dose methotrexate earlier in this chapter. Protocol 2 will result in significant myelosuppression. However, as with Protocol 1, dosing of doxorubicin will not be held for uncomplicated myelosuppression. Similarly, during the second phase of this protocol, dosing of cytarabine and thioguanine will also not be held for uncomplicated myelosuppression. However, before initiating the second phase on day 36, clinicians will assure adequate hematologic recovery, typically defined as an absolute neutrophil count greater than 750 cells per microliter and platelets greater than 100,000 cells per microliter. It is unlikely that DSB will benefit from a colony-stimulating factor during these phases of therapy. When myelosuppressive chemotherapy is given fairly continuously, as is the case with Protocol 2, there is little room for inserting doses of colony-stimulating factors on days where myelosuppressive chemotherapy is not being administered. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 463.